There is a lot of ongoing research about multiple sclerosis. The following segment reflects current thinking about MS as of 2008. No one knows what causes multiple sclerosis. What we do know is that each person with MS is likely to experience different symptoms with varying degrees of severity and disability. MS is not considered to be a fatal illness, and most people with MS have a normal life expectancy and do not become severely disabled. MS is a disease of the central nervous system, which includes the brain, the spinal cord, and the optic nerves. It is characterized by areas of inflammation, or lesions, which can occur in all parts of the central nervous system. Lesions appear as white spots on MRI images. Their size, number, and location may determine the type and severity of symptoms.
Many of the lesions in MS are silent, and there are many people living with lesions who have no symptoms whatsoever. Many patients with MS have long periods of time with no symptoms at all, and the symptoms often occur one at a time when they do happen, and often remit when the inflammatory lesions heal up. The inflammatory lesions in MS often occur with no provocation. They come and go. They can get smaller. They can get bigger. They often heal up and become invisible, disappear. So the picture in MS is very dynamic, and often when there are serial MRIs done, we can see lesions disappearing, while other lesions shrink. Often people go through their lifetime with the disease not ever having had one symptom or another, or the symptoms might recur from time to time.
The brain communicates with the body by sending messages in the form of electrical impulses through the central nervous system to the muscles. These messages control many things, including coordination, strength, vision, and sensation. The messages are sent through nerve fibers called axons. Axons are surrounded by a fatty substance called myelin, which acts as a protective insulation. In MS, the myelin may be damaged, leaving behind scarred or sclerotic tissue. Some of the axons may be permanently severed. When the brain tries to send a message down these axons, the message can be slowed down or interrupted, resulting in an MS symptom. Many researchers believe that MS is an autoimmune disease, which means that it may be the body's own defense system that is attacking the myelin.
So the results for somebody who has MS, who has inflammatory lesions, is often symptoms, which can be anything that can affect the central nervous system, such as difficulty with vision, difficulty with balance, difficulty with sensation, numbness, tingling, weakness, bladder problems. Fatigue is a very common symptom, which is also caused by inflammation.
These early MS symptoms may continue during the course of the disease and may also include cognitive and emotional symptoms such as difficulties with concentration, depression, or mood swings. An MS attack is defined as an acute episode of symptoms. It is also called a relapse or exacerbation. A recovery period from an MS attack is known as a remission, in which there is no apparent disease progression. Types of MS differ in the pattern of MS attacks and remissions and in the overall progression of the disease over time. Most people have one of three recognized types of MS. Approximately 80% of patients have relapsing remitting MS. They experience periods of clearly defined attacks, followed by partial or complete remission. More than half of people with relapsing remitting MS eventually convert to secondary progressive MS. This is characterized by a progressive worsening of symptoms with or without sudden relapses. primary progressive MS occurs in fewer than 20% of people with MS. Those with primary progressive MS experience a gradual, nearly continuous accumulation of neurological problems, with occasional plateaus and temporary minor improvements.
When a patient is suspected of having MS, the most important part of how the diagnosis is made is getting their history. What kind of symptoms they've had over time. Are those symptoms referable to the central nervous system? For example, not all numbness comes from the central nervous system. There can be numbness occurring from other causes. And then neurologic examination is important.
There is no definitive laboratory test for MS, so a variety of other tools and tests are used to rule out other disorders that can also affect the central nervous system. Magnetic resonance imaging, or MRI, is used to look for specific kinds of lesions in the central nervous system. The images that result can show areas where the myelin has been destroyed. Evoked potential tests are non-invasive electronic tests that measure the speed of brain connections. They assess the function of visual, auditory, and sensory pathways of the central nervous system. Since damage to the myelin can result in slowing of response times, these tests can detect damaged areas of the brain.
And lastly, occasionally we look at the spinal fluid to see if we have markers of inflammation in the central nervous system. Those are non-specific. They're not a diagnostic test specifically for MS. They're just part of the puzzle. It's like a jigsaw puzzle, putting it all together.
Most people with MS experience their first symptoms and are diagnosed between the ages of 15 and 50. Women are about 3 times more likely to develop the disease than men. Geographically, MS occurs more frequently in people who live their first 15 years farther from the equator than closer to it. Caucasians are more likely to get MS than people of African or Asian descent. MS is not considered to be an inherited disease and is not contagious. However, the risk of developing MS is higher for a first-degree blood relative, like a child or sibling. While the relationship between these factors and the MS population has been studied, none of them alone predict who will get the disease.
There's been a lot of research about MS and causes and potential therapies, and in fact, that's how the current treatments came to be. This research is ongoing, and there are dozens of studies looking at new interventions. Many patients who have MS are very, very keen to participate in research for this disease because there's no cure at the moment. So there are currently ongoing studies at various phases of development of new interventions. And patients should consult their physicians if it's advisable for them to participate.
The hopeful thing is that there is a lot of research going on. It's one of the things that makes practicing in the field of MS interesting for clinicians and hopeful for patients. We know that within the next several years there are going to be new and better treatments which are even more effective in changing the course of this disease.